Welcome to Passionate World Talk Radio. Educate, enlighten, entertain. And now, the show everybody's been waiting for with Dr. Marianne Matzo. And everyone dies.
Hello, and welcome to everybody. I'm Marianne Matzo, and I am your host. This show does not provide medical advice. If you have a medical emergency, please call 911. Anything you hear here should be discussed with your primary healthcare provider. This show is intended for an adult audience, and listener discretion is advised, because you never know what we're going to say. The show is produced by Passionate World Talk Radio, whose goal is to educate, enlighten, and entertain. I'm Marianne Matzo, and for the next 30 minutes, I am your host for this live call-in show. Please call 484-258-1876 with your questions. We are on the air and waiting for your call. So I have a question written in today about the use of morphine. And this is somebody who has severe shortness of breath and is on hospice care and has been given morphine. And he's very concerned that he's going to get addicted to the morphine. So he's trying not to use the morphine. And when he uses the morphine, he feels pretty well. And when he didn't use the morphine yesterday and today, he woke up today feeling horrible. And so he's wondering what he should do. So here's the thing with morphine, and particularly if you're somebody who's using your hospice benefits. If you've gone through your entire life without being addicted to anything, you don't need to be worried about becoming addicted now. And even if you have had an addictive personality, there are studies that show that people who are at the end of their life, even with a history of addiction, will still appropriately use their morphine. So in the case of this gentleman, he has breathing issues. And for him, what the morphine is doing is lowering his oxygen requirement. So let me tell you what that means. Let's say it takes, I'm going to just use cars and gallons. Let's say it takes 3 gallons of oxygen to walk from your house to the mailbox. Just with your disease, 3 gallons of oxygen. If you took your morphine before that, it would take 2 gallons of oxygen. So it's lowering, it's helping you get better gas mileage. Let's look at it that way. It's lowering how much oxygen you need to do the same thing. And so that's why he was feeling so much better, was because his issues had to do with breathing. It's helping him breathe better. When he thought, oh my gosh, I don't want to take too much of this, I need to save it. I'm not sure what people think exactly they're going to save it for, but I hear a lot of times people say, well, I need to save that in case I really need it. Well, you really need it. And you will feel so much better if you take your morphine. And what it'll really impact is your quality of life, how good you feel.
You're on the air. You're on the air. Do you have a question?
No, I was invited by Laura Holmstein, but I thought it was a listening thing. I don't really have a question, sorry.
That's okay. You can stick around and listen. There's not a problem.
Okay.
All right, so we have a listener. Please continue. Anna Marie.
Go ahead. Hello?
Yeah, we're still on the air. Go ahead.
Oh. Well, let me see. Laura Holmstein invited me to listen in. I think I've actually spoken with you before.
Yes, you have. Let me go get Anna Marie back. Anna Marie? Are you still on the line, Anna Marie? You're on the air.
Yes, I have a question for Dr. Matzo.
Okay, just a second. Anna Marie, are you here? We seem to have lost her. Wow, I have no idea what happened to her. Well, while we're waiting for Anna Marie to come back and join us, we have a gentleman on the line waiting to ask a question. And Anna Marie was talking about the use of morphine and the problem of getting addicted. Anna Marie? Oh, this has never happened before. Oh.
Is the morphine used for hospice?
The morphine is used for when somebody had trouble breathing, and he was afraid that he was going to get addicted to it. So he asked Anna Marie whether or not he should continue using it, because when he did use it, it made him feel better. And she was saying that doctor said that a doctor who she speaks with recommended that if you were never addicted to morphine during your life, then you should not worry about being addicted to it when you really need it for the pain. And she went on to say that the same doctor did a study in which they found that even if you were addicted, it wasn't going to affect you when you were using it to help you bear the pain easier. Which I felt was very interesting, because I would think that if you were already addicted to a narcotic like morphine, that you would not be allowed to use it, or at least use it for small dosage.
Huh.
I mean, that's what I think. I'm not sure, but and when she rejoins us, she'll be able to say whether or not it's damaging or not. But I got the sense from her conversation that if you're in pain and the morphine makes it easier for you to breathe and to be more comfortable, that you can also sleep, then go ahead and take it.
Right.
That it was more important to feel comfortable and to not have the pain than to try and brave it out, because some pain is really difficult to bear. And I know, having pain myself different times with my fibromyalgia or my arthritis, or when your knee gets out of joint, for example, that the pain is so excruciating that you really need something to at least tone it down and take off the edge, so to speak. So it's bearable for you to go on with your life.
Right.
So it's not hurting your quality of living.
I think pain management is really important, and I'll just give you a little backstory on mine. I've had 2 craniotomies for glioblastoma brain tumor, and the second craniotomy was excruciatingly painful, and the nurse was giving me fentanyl in micrograms, which would help a little bit for a few moments, but any movement, any increase in intracranial pressure, like to move around, was off the charts.
So you needed something in order to maintain it from driving you crazy.
Yeah, I thought I don't even know how to explain the pain. I've never had pain like that before. It has nothing. I don't think they were giving me morphine. I think it was fentanyl.
Okay. Excuse me.
It helped temporarily for maybe a few moments, but it would knock me out, and then I'd wake up in pain again.
I know,
So
it's
what would you-
difficult.
Lillian?
Yes,
Yeah.
Lillian?
What would
Hi,
you
it's
suggest?
Marianne. I
it's
think I must have
Marianne.
gotten cut off from you.
I think you got cut off. We do have a caller on the line that's talking about some of the severe pain that she had.
Okay, what's our caller's name?
Can we have your name, please?
My name?
Yes.
You're paying with? Oh, my name's Lisa.
Her name is Lisa.
Hi, Lisa. It's Marianne. I'm sorry, I was disconnected, so I didn't
I
hear the
can't
beginning
hear
of your
The
question.
person on your end.
Do you mind telling me what your question is?
She wants to know what your question is.
When I'm experiencing excruciating pain and telling the nurses that I'm still in excruciating pain, who do I ask for?
She wants to know when she has excruciating pain, what does she ask for or who does she ask for? Does she ask the nurses or does she ask the doctor? Who does she go to?
Well, are you in
A little backstory on this. The doctor left to go to Boston to move his family to Oklahoma City and put a resident in charge who left. And so the only person that was taking care of me was a nurse. And he only ordered the fentanyl.
Okay, so she's saying that her regular doctor left, and then the nurse left, and she had a resident, and all he ordered for her was what's it called?
Fentanyl.
Sentinel. Okay.
What kind of disease do you have?
And they discharged me in pain and vomiting severely, profusely.
Okay. Anne-Marie wants to know what kind of disease you have.
Glioblastoma. Multiple.
Okay,
Mhm.
all right. I can hear.
Glioblastoma, brain cancer.
Well, she can't hear you. That's the problem.
Right.
What do I
can hear
do?
her. So your pain, if you were to rate it on a 0 to 10 scale, with 0
Hello?
being no pain and 10.
Okay, she wants to know how you rate your pain from 0, which is no pain, up to 10, which is severe pain.
I would say about 1,000.
She says about 1,000.
Yeah.
Okay.
It's the
And
worst
how
pain.
how would you describe that pain?
Excruciating.
Okay, she wants to know how you would describe that pain.
Oh, God.
Is it sharp, dull, aching?
Is it sharp, achy? Is it all the time? Does it come in bouts or waves?
It was very, very sharp and very, very strong, and it would increase even worse with movement.
Okay, very strong.
And where I can hear her, Lillian. Where is the pain?
And where is the pain?
I don't have it now. It was after my last craniotomy.
It was after her last. Oh, sorry.
So where was it? Was it in your head?
Was it in your head?
Yes.
But you're not having it now?
Probably in the center of my brain.
She said, okay. She's.
Any nausea?
Any nausea?
Oh, yes. I was puking my guts out. They discharged me like that with that pain and vomiting.
I would say that in that situation, you would need to go right back to the emergency room, because that could be a very dangerous
I filled up about 5 or 6 of them little green vomit bags.
She said you should have gone back into the emergency room to get it checked out.
But I was in the ICU.
But they discharged you like that, and so you should go back to the emergency room and say, that's a serious situation.
We're still here.
But I guess you can't hear me. Hey, Lily?
ICU.
She cannot hear you. You can hear her, but she cannot hear you. So everything that you say, I need to say to her.
All right, so tell her that I appreciate that she was in the ICU, but with that kind of pain and the fact that she was vomiting, that's a serious symptom, and she has to go back to the emergency room and let them treat her. If she wanted to go to a different emergency room than where she went,
and the reason I'm asking is that glioblastomas are aggressive form of brain cancer, and they grow back very quickly.
Anne-Marie suggests that you go back to an emergency room if you're not happy with the first hospital that you were in because they discharged you too early. She suggests that you go to another hospital's emergency room and get it looked at and treated because the type of disease that you have is very dangerous.
Right.
Okay, well,
thank you very much, Marianne.
Anne-Marie, are you still having that pain?
Me?
Yes.
Lisa? No.
No. Okay.
All right. So her question was, who should she have talked to?
And I think the doctor forgot to prescribe some steroids to keep my brain from swelling.
Right. But if she's...
So we got that straight away. It was just kind of a joke.
So if you're having pain and you're vomiting and you have a history of brain tumors, you need an emergency room because it's a serious situation. And so it's good that the pain's not there now, but if that were to happen again, you need to go to the emergency room.
Anne-Marie says that if you should develop the pain and the vomiting again, you should go into the emergency room.
Okay, thank you very much.
Take care.
Take care. Okay, she's off the line. I had a gentleman that called in, but I think he dropped the call too. We're going through a severe thunderstorm over here with lightning, so things may be a little chaotic.
So when we were disconnected, I was still talking away to myself, Lillian.
I apologize for that. I mean, you could hear me asking where you were. We had a gentleman who called in who wanted to talk to you. I felt really silly, but I pretty much reiterated what you said about morphine and about the patient you were talking about. So I think I did pretty good considering I'm not a medical person.
Well, we might have to give you an honorary nursing degree or a pin or something, Lillian. I'm not sure.
Well, I just tried to reiterate what you said, and I do pay attention when you do speak. So
that was great. That I know that's hard to be the intermediary in a situation like that.
Well, you don't want dead air space, and I don't. My singing days never began, and I'm still working on my comedy routine.
So last week, Lillian, what were we talking about? Quality of life, and I said we should talk about that on the show?
Yes, we should, and I remembered that you told me I need to ask my question. So my question from last week was, when you have a family member at home and you're taking care of them, how is it a good idea to put a baby monitor or something, even like a video monitor in the bedroom? So if that person is incapable of speaking, how do you know when they need you or when they want to talk to you about something?
You know, and I think that those, I hate the term, that it's a baby monitor for an adult, but that's what they sell them as. Those baby monitors are good so that you can feel like you can get some sleep, and you'll hear them if, they get up or they fall or they cry out. So from that point of view, they're good. My concern, though, would be that if you're like excessively looking at the monitor or something like that could be.
You're on the air. Hello? You're on the air. This is crazy. PWR Network, you're on the air.
Hi, it's Marianne.
Hi, Marianne. We keep on losing you.
I know. I'm talking away, and then I hear like music, like the angels are coming, and I think somebody's calling in, but they're not. What it is I've gotten disconnected. So, go figure.
It's going to be one of those kind of days, I suspect. I don't know why, but it seems to be becoming a real problem. We certainly didn't have this problem last week, so I'm not quite sure what the problem is.
I even moved up to the place like right next to my internet router so that I wouldn't have any barriers that way. So what I was saying was that those monitors are a good idea so that you can feel like if a person's moving or something's happening, you'll know about it. But my warning to people would be is not to be too obsessive about it. You know, like I've seen people with babies who have the monitors and they have the video and all they do is constantly checking it and they're obsessed with it and they're not, paying attention to what they're actually doing in the rest of their life. So I just would warn people to be aware that could be an easy pitfall to fall into and, use it as a safety monitor and don't be obsessive about it. Does that make sense to you?
It makes sense to me. In fact, one of the gentlemen here at the community center, his wife is in the health center over here. So he installed a baby monitor in his wife's room, and they talk to each other through the baby monitor because he's not allowed to go in and see her because of the coronavirus. And
that's a creative idea.
Isn't that a creative? I thought I mentioned that because he goes over once a day in the evening and they talk. And then they're on for 15, 20 minutes and they say goodbyes and then he walks away. And I just think what a great idea for somebody to keep in touch with their loved one if they're in a position where they're not allowed to see their loved one because of the epidemic.
Yeah, that is a good idea. Or FaceTime if the aide or whoever was able to, he wouldn't even have to physically go over there. They could FaceTime each other and be able to see each other and talk to each other. So with the technology, there's lots of creative ways that we can stay in touch with people and still keep them safe from exposure to the virus. So definitely think of all the different ways, or for us older people, ask your grandkids what are the other ways that you can use technology so that you can stay in touch with people, because this is going on for a long time and it looks like it's going to go on for even longer.
Yeah, we're back in lockdown again. Governor Wolf of Pennsylvania stated that cases were up, especially in the senior community, so we're basically in the yellow zone again, which means that you can leave the campus, but then you have to come back and take your clothes off and throw them in the washing machine, and you need to take a shower, and anything you touch either needs to be thrown away or fumigate. So yeah, it's a pain.
Wow.
When I go marketing, yes, I leave my plastic bags in the hallway. I take everything out of the bags. I put them in the sink, and I throw away the bags because I don't want to bring any possible contagion into my residence.
Wow.
Yeah, it's pretty tight. It's pretty tough.
So were you able to hear what I was saying about the question from the man who had difficulty breathing and the morphine? Did that get cut off?
I got the fact that I got was that if you've never been addicted before, chances are you weren't going to get addicted now. And also studies have shown even if you were addicted, if you really needed to take the stuff, you should, and just have somebody monitor you for not taking any more than you need to take?
Well, actually, what the studies say is that if you've had a history of addiction, the studies show that people who have a history of addiction do not abuse or misuse the opioids when they're at the end of life. So you don't need additional monitoring. The studies show that people, even with that history, will still appropriately use the morphine. So for this man, he's using it because he has difficulty breathing, and he's worried that he didn't take it yesterday, and he woke up feeling really rotten today. And he's like, I'm worried about getting addicted, but what should I do? And so what I would say to him is take your morphine. The reason he was prescribed the morphine, in this case with his lung disease, is that it lowers how much oxygen your body really needs in order to work. So think of it as if your body was a car and you took the morphine, it would increase the gas mileage. So you would be able to get farther and feel better if you use the morphine, because it's lowering the requirement of the oxygen in your body, and therefore you're going to feel better, and you're going to sleep better, and you're going to be able to talk to people, and you'll have a better quality of life. So don't worry about getting addicted. This man is in hospice. It's appropriately ordered. It's appropriate for the symptoms that he has. And really what he's doing by not taking his morphine is helping himself feel a lot worse. So if he took it, he would be able to do more and interact with people and sleep better, because God knows if you're not sleeping well, you really feel pretty crappy. And so at the end of life, when you're in hospice, when you have a life-threatening illness, the use of morphine is perfectly appropriate. There will be times along the way that you might say, I used to be able to take 0.5 milligrams of morphine and feel perfectly good, but now I don't feel quite so good. And the healthcare practitioner wants to increase the dose. And you say, oh my God, they're increasing the dose because I'm addicted. No. What's happened is that your body becomes tolerant to the medicine, meaning your physiology has figured out how to metabolize the morphine, and you use it more appropriately. I mean, your body is using it more efficiently, I guess would be a better way to say it. And it's like people with alcohol. There are some people who can drink a six-pack and not even feel it. If you were to give me a half a beer, watch out, because I am intolerant to alcohol. Anybody who's ever had a drink with me, it doesn't take much. Okay?
No, I go to sleep myself, so I know.
So that's what happens with the morphine, is that your body figures it out, and so in order to manage the symptom, you're going to need more. We expect that to happen. We're not surprised when that happens. We don't say, oh my God, what are you doing? We say, oh, your body figured it out. We need to adjust the dose. The other thing with morphine, regular morphine, is that it's meant to work for 4 hours. Don't think you can take it once at night and have it last for 24 hours. It doesn't work that way. It lasts 4 hours. And so you might see on your prescription bottle, take, 0.25 every 4 hours is needed. The reason it says every 4 hours is because that's how long it'll last. So, again, manage your expectations. Don't say to yourself, oh my God, I took it last night and now I'm up this morning and I'm having trouble breathing. Well, that makes perfect sense. It only lasted 4 hours. So these are all the details that don't always get communicated to people, and that's why we're here at Everyone Dies, is to hear your questions, explain to you how it works, why it works the way it does, and let us help you so that you can feel better. We'd love to hear from you. You can write in your questions if you're busy or away from the telephone at this time, our number here is 484-258-1876, and we'd love to hear from you.
Or you can email us at lsc@passionateworldtalkradio.com. That's lsc@passionateworldtalkradio.com. I got a question from you. What happens when a system, I have the kind of system that throws out drugs very, very quickly. And apparently the stronger they are, the faster it gets thrown out. So how do you readjust the amount that a person should have with a narcotic?
So there's a thing called half-life. Every drug has a half-life. And what a half-life is how long it, on the average, it would take for half of the drug to be cleared from your system. Okay? So we can look up any drug that we were going to prescribe to you, Lillian, and we'd say, well, we're going to give you Haldol to manage your anxiety. We know that Haldol's half-life is something like a couple of weeks. We know that's going to stay in your system, okay? So we can adjust that dosage. We wouldn't give you as much because we know that's going to stay in your system for a long time. There are other drugs, certain antidepressants that have a very fast half-life. They're out of your system. Their half-life is like 12 hours. They're out of your system completely. And so we know that maybe we were going to need to give you a little bit higher dose because you metabolize your fast metabolizer. It has a short half-life, so it's going to be out of your system pretty darn quickly. So what you should do is when you go to your doctor, your healthcare practitioner, your nurse practitioner, you say, I tend to clear out my medicine pretty quickly. Let them know that so that they can take that into consideration when they're giving you your dose. Like when I'm doing pain management, I need to know if somebody has had a history of alcoholism or drug use because of that tolerance piece of it. I know I can't start that person on a typically low dose because it's not going to touch them. I'm going to have to start them at a higher dose. Or like if I go in and have surgery or something happen, I tell the anesthesiologist, I'm really sensitive to the anesthesia. A little goes a long way. I communicate that so that I don't get totally snowed by the normal dose of medicine. So it's communication with your healthcare practitioner, letting them know your history, and then your healthcare practitioner knowing the half-life of the drug. It usually takes about 5 or 6 half-lives for the body to completely clear it out. So if a half-life is 1 day, and you take a drug today, it's going to take about 5 days to be completely gone from your system. There will be some effect of that drug in your body. Now, is it enough to cause side effects? Is it enough to do anything? That depends on the medicine, but it can. And so half-life is an important piece that your prescriber looks at when deciding on the dosage of the medicine. Does that make sense?
Yeah, it does. It does. Which lets me believe that even when you're using bufferin or aspirin, that too remains in your system a lot longer than when they say it does?
Well, they usually don't say on the bottle how long a bufferin is going to stay in your system. They might say take one every 6 hours, and if you experience any bleeding, be sure to call your doctor because those aspirin products are going to thin your blood. So there are people like I can't take, the low-dose baby aspirin every day to prevent heart disease because I get all bleedy.
Yeah.
I just can't do it. So, I know that about myself. I know that that's not an option for me. Other people, that's, for, a lot, those studies were done with men, they do perfectly well. They don't have any bleeding issues. So it's communication, talking to your healthcare practitioner, letting them know about you in particular.
Well, how many times should a person be taking that type of medication? I was told by my doctor, he says, well, I take Bear, for example, adult Bear, and he says, don't take more than 4 of them. He says, because over 4, you're really doping up your system. So I wonder.
Well, I think what he's saying is that over 4, you're going to probably run into some bleeding issues. So if you're having headaches or something, then you need to maybe try acetaminophen or a different kind of medicine to manage the headache. Or talk to them and say, listen, a symptom, there are so many times when I take the Bear and I'm taking 4 or 5 of them and I'm still having pain or issues. What else can I take? Don't, I get a little crazy sometimes when people like, especially they'll go on Facebook and they'll say, so I'm having this symptom, what should I do? It's like, sister, call your doctor and discuss it with them. Because it's not just your headache, like with the woman called in. Well, is it a headache or do you have glioblastoma? Those are 2 different situations. And my response to you is going to be different. If, once a year you get a headache, or if you've had brain surgery for glioblastoma. Do you see what I mean?
Yeah.
So don't cherry pick a symptom and, say, well, what do I do for this? Because if you say that to me, like with our caller, I had about 20 questions, right?
Right.
Because it's not just a simple, oh, you know what, just rub some, whatever kind of cream, aloe cream on your head and you're going to feel better.
Right.
No, it's more complicated than that. The human body is more complicated than that. It's not a one-size-fits-all situation. And I've had patients, say, well, are you just experimenting it with me? And it's like, look, if you had a barcode on your arm that I could scan that would say, all right, this person needs a higher dose of this, a lower dose of this antidepressant would work better than this antidepressant, my God, my job would be so much easier.
Right.
But we don't have barcodes. So, yeah, I got to start with this one at this dose, and then we have to see how you respond, and then we adjust. It's a process until we know this either works or it doesn't work.
Right.
And then we'll go to the next one.
Yeah. Okay. I was just curious because I know that a lot of people use aspirin and the other type of painkillers, Tylenol and some of the others for more than just when they have a headache. And some of them, or Aleve, for example, and they come in 8-hour, 12-hour tablets, but the pain starts coming back before the 8 hours or the 12 hours are over, and they give themselves another pill, even though the instructions say don't take the next one until the official 8 or 10 hours are over with.
And then they can run into problems with their liver and their kidney, and they say, what? My liver's having problems, but I don't drink. Well, what about all that Excedrin that you've been taking, like people with fibromyalgia or other kinds of diseases like that? You self-treat what you think is doing the right thing, not realizing, because how would you know? You haven't gone to school for this stuff, and you ruin your kidney or ruin your liver.
Well,
really, the people say, well, I don't want to bother the doctor. Please
bother him.
us.
Yeah.
Please call us.
Yeah, I'm one of those kind of people, but I also know that you can only take so much of that stuff, and you're really not taking care of your pain. You're just piling more and more of that stuff in your system, which is not going to do good things to your system.
And you're only treating the symptom. You're not treating the cause.
Exactly.
So if your body's out of alignment, and really what you should be doing is going to a chiropractor to get yourself back into alignment, all the drugs in the world aren't going to fix the fact that, one hip is higher than the other, and that's why you're having that pain.
Yeah.
So, call in and talk to us, and I'll tell you the truth and give you a suggestion. You might not like the suggestions, especially if I say, walk some more or something like that, but those are the realities of taking care of your body and dealing with pain and other symptoms. So I want to thank you for spending time with me during our show, Everyone Dies. You can read our blogs and listen to our podcast at everyonedies.org. Remember, you can listen to Passionate World Radio on Spreaker and our shows wherever you listen to podcasts. We are here every Wednesday p.m. to take your calls and answer your questions related to life-threatening illness, dying, and death. I hope that you live your best life every day, and remember, every day is a gift. Thank you for listening.
And if you want to listen to Everyone Dies, please go over to https://passionateworldtalkradio.com, right-hand side of the page. Scroll down to Everyone Dies, click on that, and you will be able to listen to the Spreaker. And you can also listen on iTunes, iHeartRadio. You can also listen on Google, Podchaser, and Apple, to name a few. Twitter, Facebook, YouTube, LinkedIn. So please go over and take a good look. And if you want to send us a question, again, the email to you is lsc@passionateworldtalkradio.com. Thank you very much and have a great evening.